The next section, we're going to talk about some pharmacologic bases in monitored anesthesia care techniques, which is really the same. The pharmacologic bases are the same between MAC and general, or even regional, depending on what you give and where to give it to. So, the objective of any dosing regimen is to deliver a therapeutic concentration of a drug to its site of action, and most of the time for us, that's the brain. The therapeutic response to a particular drug concentration is described by the pharmacodynamic of that particular patient drug combination. And again, patient drug combination, the drug with every patient acting differently to it. By the end of the procedure, the drug concentration should have decreased to a level compatible with rapid recovery, obviously. When using drugs such as propofol, the adjustable rate continuous infusions are the most logical method of maintaining a desired therapeutic concentration. So, you will always know my choice if you work with me up in GI for a quick endoscopy if I want intermittent boluses or continuous infusion. Well, infusions let you have a stable plasma concentration so you don't overdose and underdose the patient intermittently. Now, how to avoid excessive sedation? Well, drugs should be titrated in small increments or by adjustable infusion, rather than given a larger dose according to a predetermined notion of efficacy. So, giving a 2 milligram per kilogram propofol is okay in some patients, but if you're taking care of a 2-year-old, don't even talk to me about it. If you're taking care of somebody with EF of 15%, don't talk to me about it. In an ideal dosing regimen, an effective concentration of a drug is achieved and then adjusted according to the magnitude of the level of stimulation. If the noxious stimulation is increased or decreased, the concentration is increased or decreased. So that's how you get to an ideal MAC with avoiding excessive overdose. Now, this graph shows you the plasma drug concentration over time, and the green line is the plasma concentration of an infusion compared to the I think yellow or orange line of the intermittent boluses. When you give intermittent boluses, there is significant fluctuations in drug concentration. You can see how often we are in the excessive sedation range or in inadequate sedation. The plasma concentration are either above or below where you want to be, so don't give intermittent boluses when you have access to a pump. Again, look at the ideal therapeutic range and how much easier it is to maintain it with a continuous infusion. Continuous infusion lead to less fluctuations in the concentration of the drug, reduce the number of episodes of inadequate or excessive sedation, reduce the total amount of drug given to facilitate a more rapid recovery. When you give a bolus of a drug, there's an immediate distribution phase, and this causes a brisk decline in your plasma concentration of the drug. And you can see here the blue line is the plasma concentration and the yellow line is the effect on EEG, and it closely follows it, as you can see. And this happens because the mechanism of termination of action of most of the drugs we use is from redistribution to the rapidly equilibrium vessel-rich group of part of the body. Now, this slide is near and dear to me. I love the compartment models when it comes to pharmacokinetics. And most of our drugs, we use the 3-compartment model. So, 1 compartment, 2 compartment, 3-compartment model. So in the 3-compartment model, after IV injection of a drug, the initial rapid distribution phase is followed by a second slower distribution phase before getting to the equilibrium. So the plasma concentration is the sum of the 3 exponential terms in the CT formula. So concentration at a specific time is determined by what happens in each compartment. So in this graph, Ct is the concentration at a specific time, T is the time. Capital A is the intercept of the rapid distribution phase. Alpha is the rate constant for the rapid distribution phase. B is the intercept of the slower distribution phase. Beta, the rate constant for that phase. C is the intercept for the elimination phase line, and lambda is the gamma is the hybrid rate constant for that phase. And so the drug is injected into and eliminated from the central compartment. This drug is reversibly transferred between the central compartment and the two peripheral compartments, which accounts for the two distribution phases. Drug transfer between the central and the more rapidly equilibrating peripheral compartment is characterized by the first order rate constant, or K12 and K21. Transfer in and out of the more slowly equilibrating compartment is characterized by the rate constant of K13 and 31. In this model, there are three compartments, as you can see, V1, V2, V3, whose sum equals the VSS, or the total. And there are three clearances: the rapid intercompartmental clearance, the slow intercompartmental clearance, and the elimination clearance. And this formula, the Ct equals AE to the minus alpha T, etc., is actually very useful in terms of understanding how drugs work and why it is that, you give a bolus, it quickly goes away, versus when you stop an infusion, how long it actually takes for that drug effect to be gone so a patient wakes up. So when you stop a drug, but when you give a drug, you have this initial rapid distribution phase. So you give a bolus, rapidly distributes. This is followed by slow distribution phase, and then the terminal phase. And again, this is how many minutes after you give a bolus of a drug, what happens to the plasma concentration. Now, the concept of context sensitivity, half-time, you thought you were done with it. The effects of distribution on plasma concentration varies in both magnitude and direction over time. It depends on the drug concentration gradients between the various compartments. For example, during the early part of an infusion of a lipophilic drug like propofol, distributive factors tend to decrease plasma concentration as the drug is transported to the unsaturated peripheral tissue. After the infusion is discontinued, drug will return from the peripheral tissue and re-enter the central circulation. Concentration half-time describes the time required for the plasma concentration to decline by 50% after you stop an infusion of a particular duration. This context-sensitive half-time reflects the combined effect of distribution on metabolism, on drug disposition, and thereby the drug action. As the infusion duration increases, as you can imagine, the context-sensitive half-time of all drugs increase. In the case of fentanyl, which irreversibly eliminated from the plasma by liver, it's immediately replaced by the drug returning from the peripheral compartments. Even though fentanyl has a shorter elimination half-time than sufentanil, for fentanyl it's 462 minutes, for sufenta is 577 minutes. The context-sensitive half-time of fentanyl is much larger than sufenta when you give it for more than 2 hours of infusion. So remember the 2-hour infusion mark. So if you want to run a fentanyl infusion, fine for 2 hours. For a 4-hour, 6-hour long case, probably not the best choice when it comes to drug choice. This storage and later release of fentanyl from the from the fentanyl from the peripheral tissue is going to be much larger compared to sufentanil when it comes to like a long case. But again, for a short case, that's not the problem. And keep in mind that the context-sensitive half-time of all the drugs bear no relationship to their elimination half-time. So a drug with high versus low elimination half-time doesn't mean that there's going to be a correlation with the context-sensitive half-time. It's a matter of the pharmacokinetics in a multi-compartment model. So how does context-sensitive half-time relate to time to recovery? The context-sensitive half-time doesn't directly describe how long it will take the patient to recover from the drug effect. It only describes how long it will take for the plasma concentration to drop by 50% after you stop it. The time to recover depends on multiple other factors. The difference between plasma concentration at the end of the infusion, the plasma concentration below which awakening can happen based on a specific drug. Again, the context-sensitive half-time is a reflection of plasma drug decay, but awakening from anesthesia is a function of effect site concentration decay or the brain site concentration decay. Changes in the effect site concentration demonstrate a variable time lag behind changes in plasma drug concentration. And again, in this graph, you can see the therapeutic range of a drug, and when you stop an infusion. And the blue line again is the drug concentration, and the orange line is the EEG pattern. So again, they are different, even though there is a correlation. When you give a bolus, there is a delay before the onset of clinical effect. This delay occurs because the plasma is not usually where the drug works, and the drug has to go to the brain or the site of action. The half-time of equilibration between the drug concentration in the blood and the drug effect is T1/2 KEO. Drugs with short T1/2 KEO will equilibrate more rapidly with the brain and have a shorter delay in onset than drugs that have longer T1/2 KEO. Propofol, thibental, alfentanil, if you can get them nowadays, they have shorter T1/2 KEO compared to drugs like midazolam, sofenta, and fentanyl, so quicker. The T1/2 KEO is an important determinant of bolus spacing when titrating drugs to clinical effect. In the case of a drug like midazolam and propofol, boluses of a drug should be spaced far enough apart to allow the full peak effect to be clinically appreciated before you give any more dosing. Otherwise, you will overdose a patient. For example, even if the shortest coded equilibration half-time for midazolam is 0.9 minutes is used, it will take 2.5 minutes for the effective concentration to be 87.5% of equilibrated. So even for a short-acting drug like midazolam, you have to take time. Lastly, the effect of cardiac output and the bolus dosing and the time you put in between the boluses. A low cardiac output will markedly delay drug arrival at the site of action. You can imagine, you have to use the heart to pump the blood to the effect site. So low cardiac output, the onset is going to be delayed. And if there is inefficient time before you give a second dose, there's going to be significant overdose of the patient. The effect of the initial bolus of most of our drugs are terminated by redistribution, right? And redistribution depends on blood flow to redistribution sites. If there is reduced blood flow to the redistribution sites because of a pre-existing or iatrogenic decrease in cardiac output, there's going to be dangerous adverse effects of these drugs because of the delayed and markedly prolonged duration of action. Now, an example that you probably have or you will work on is a patient who needs a quick cardioversion who has EF of 15%. So how much propofol do you give this patient? And more importantly, how much do you wait before you give more propofol if you think it's not enough? So a general rule of thumb is, for somebody to lose consciousness, which is your goal for cardioversion. You just want the patient to briefly lose consciousness. So your goal is to give as many cc's as percentage of cardiac output to achieve that goal. So somebody with, milligrams, not cc's. So somebody with EF of 15%, you give 15 milligram of propofol. That usually leads to getting unconscious, so they can do the procedure and patient doesn't feel it, and then rapid recovery. Somebody with EF of 40%, you give 40 milligram. This doesn't work very well in patients with higher EFs, like somebody EF of 65%. 65 is usually not enough, but usually we do cardioversion in people with lower ejection fraction. But how long do you wait? Somebody with EF of 15%, you give 15 milligram of propofol. Typically, you gotta wait 5 or 6 minutes for that drug to take effect, which is not the case. When you're taking care of a healthy patient, give 200 of propofol, and they're asleep within 20 seconds. Not the case in somebody with low ejection fraction. So if you give 15 milligram, wait 2 minutes, nothing happens, give another 15 milligram, 2 minutes, nothing happens, give another 15 milligram. Now you've given 3 times as much as what you should have to this patient because you didn't wait long enough. And this patient's going to be hypotensive and not breathing, and going to take you 20 minutes to recover the patient for a case that should have been 6 minutes.